name is Muhammad Arif, consultant physical therapy here. Before going to start my presentation, first of all, I want to thank Dr. Imran, as I was recently diagnosed with acute appendicitis. So I was more concerned about this scar rather than my severe pain. So I requested sir, so he did a laparoscopic appendectomy, and I'm pain free and mobile and active. Thank you sir once again. So today my topic is low back pain and physical therapy management. As you know, that physical therapy has become an integral part of health sciences. So in particularly low back pain, physical therapy has a greater advantage to address the issue. There are different definitions of low back pain depending on the source. According to the European Guidelines for Prevention of Low Back Pain, low back pain is defined as pain and discomfort localized below the costal margin, inferior to the costal margin, and above the inferior gluteal folds with or without leg pain. In USA, it is the commonest cause of limitation of activity in those under the age of 45. This is some statistics of low back pain. Low back pain is the fifth most common reason for physician visits and affects nearly 60 to 80% of people throughout their lifetime. Some studies have shown that up to 23% of the world's adults suffer from chronic low back pain. This population has also shown a 1-year recurrence rate of 24% to 80%. Some estimates of lifetime prevalence are as high as 84% in the adult population. A systematic review demonstrated an annual rate of adolescents suffering from back pain of 11.8% to 33%, 11 to 12% of the population being disabled by low back pain. I have given references at the end of this presentation. Low back pain is usually categorized in 3 subtypes: acute, subacute, and chronic low back pain. This subdivision is based on the duration of the back pain. Acute low back pain is an episode of low back pain for less than 6 weeks. Subacute low back pain between 6 and 12 weeks, and chronic low back pain for 12 weeks or more. Low back pain that has been present for longer than 3 months is considered chronic. More than 80% of the all health care costs can be attributed to chronic low back pain. The lower back where most back pain occurs includes the 5 vertebrae in the lumbar region and supports much of the weight of the upper body. The space between the vertebrae are maintained by intervertebral discs that act like shock absorbers throughout the spinal column to cushion the bone as the body moves. Ligaments hold the vertebrae in place, and tendons attach the muscles to the spinal column. The spine extends from the skull to the coccyx and includes the cervical, thoracic, lumbar, and sacral regions. The lumbar spine consists of 5 movable vertebrae, numbered L1 to L5. The lumbar vertebrae as a group produce a lordotic curve. The intervertebral discs are responsible for the mobility without sacrificing the supportive strength of the vertebral column. The intervertebral discs along with the laminae, pedicles, and the articular process of adjacent vertebrae create a space through which spinal nerves exit. The complex anatomy of the lumbar region is a remarkable combination of these strong vertebrae, with their multiple body elements linked by joint capsules and flexible ligaments, tendons, large muscles, and highly sensitive nerves. It also has a complicated innervation and vascular supply. The low back vertebrae are larger in size, thicker block-like structures of dense form. From the front or anterior, the vertebral body appears rounded. However, the posterior structure is different: lamina, pedicles, and body processes. These processes and vertebral arches create the monospinal canal for lumbar nerve structures and the flora and vena. As you can see, this is the pictorial structure of the skeletal part of the lumbar region. The anterior part of the vertebral bodies are larger in size because they bear the maximum weight of upper body. At the posterior side, superior articular process is present, where the inferior articular process of upper vertebrae gets attached. Pedicles and laminas, which are the basically pedicle is present between the transverse process and the vertebral body, and it guards the spinal column from the lateral side, whereas the lamina guards the spinal column from the posterior side. In particular, spinal stenosis is a condition where the intervertebral foramen gets constricted and the nerves exiting gets irritated or pinched. So spinal surgeons does a decompressive leptotomy or lepectomy to increase the intervertebral format to ease the nerves. This is the anterior view of the lumbar vertebrae, rear view, lateral view, and posterior view. As you can see, there is a gel-like disc cushion present between the two vertebrae, mainly made by the nucleus pulposus and annulus fibrosus, a thick cartilage surrounding the nucleus pulposus, and the spinal canal is running posterior of the vertebral body. Strong ligaments are present in the spinous ligaments and the ligamentum clavum. A single intervertebral disc separates two vertebral bodies and together with the passage joints form a strong A single intervertebral disc separates two vertebral bodies and together with the passage joints form a strong joint complex that enables the spine to bend and twist. One pair of passage joints from the top of the superior vertebral body connects to the lower, or a rear pair of passage joints. Passage joints are two synovial joints, meaning they are aligned with cartilage and the joints capsule. These are the passage joints. The passage joints are two synovial joints, meaning they are aligned with cartilage and the joint capsule. In cases synovial fluid enables joints to glide during movement. Passage joint syndrome, very common, may develop as a consequence of aging and degenerative spinal changes that cause lower back pain. This is the anatomy of the intervertebral disc. This is nucleus pulposus, mainly made by the antiperson of water, a gel-like cushion. Surrounding surface is annulus fibrosus, and these are the anklets, superior and inferior anklets, which attach to the upper vertebrae and the lower vertebrae, anterior cruciate ligament and posterior cruciate ligament. What lumbar vertebrae provide attachment points for numerous muscles: interspinalis, intertransversi, latissimus dorsi, rotators, insertus, posterior inferior. Causes of low back pain. Causes of low back pain include musculoskeletal. The musculoskeletal cause of low back pain includes muscular strain, ligament strain, acute and chronic, traumatic injury, prolapse intervertebral disc. Degenerative includes osteoarthritis. Rheumatic cause of low back pain includes ankylosing spondylitis. It's a condition of arthritis. It's a type of arthritis that involves joints and ligaments of spine. Neoplastic primary or secondary tumors refer from any other abdominal portion or renal or gynecological tissue. Infectious cause of low back pain includes like tuberculosis, herpes zoster, and osteomyelitis, and any other infectious causes inside the body. Muscle strain and sciatica. Sciatica is the most common problem of the low back pain. Muscle strain is often the cause of back pain from heavy lifting or vigorous exercise, but sometimes it's due to small jelly-free discs meant to protect the space between vertebrae. When one of these discs bulges or breaks, it can push on a nerve. When it is a sciatic nerve, pain runs from the buttock down to one leg. This is called sciatica. The cause could be a workout. Overdoing it at the gym or sports is one of the most common causes of overextended muscles leading to low back pain. Particularly when you are especially vulnerable, if you tend to be inactive during the work week and then spend hours at the gym or softball field on the weekend. Postures, the ergonomics. Your back supports weight best when you don't slouch. This means sitting with good lumbar support for your lower back, shoulders back, with feet resting on a slow stool. When standing, keep weight evenly balanced on both feet. Herniated disc, most common problem. The spines vertebrae are cushioned by gel-like disc, as I have mentioned previously. They are prone to wear and tear from aging or injuries. A weakened disc may rupture or bulge and putting pressure on the spinal nerve roots. In the intervertebral foramen, where the nerves are exiting, the discs are herniated into that intervertebral foramen and putting pressure on the nerves. This is known as herniated disc and can cause intense pain. Chronic conditions could be there. Several chronic conditions can lead to low back pain. Spinal stenosis is a narrowing of the space around the spinal cord, which can put pressure on the spinal nerves. And ankylosing spondylitis inflames the joints of the spine, and sometimes the shoulders, hips, ribs, and other areas too. It causes chronic back pain and stiffness. In serious cases, spinal vertebrae start fused together. As you can see, there is the bamboo spine, fusion of bones. Vertebral bones are fused together. It's a condition of presentation of ankylosing spondylitis. The surfaces are inflamed, bony spikes can be present. Fibromyalgia causes widespread muscle aches and including back pain. Differential diagnosis is very important. You can make it on the basis of biological examination of the lumbar spine. Mechanical includes lumbar strand of strain, rheumatic disc, and spinal stenosis, degenerative process of disc in facet joint, compression fractures, and spondylolisthesis. Whereas the systemic includes malignancy, multiple myeloma, infection, metastatic carcinoma, osteomyelitis, infection of the bones, tuberculosis, brucellosis, inflammation, and ankylosing spondylitis. Whereas the referee includes acute aneurysm, pelvic disease, prostatitis, endometriosis, renal disease, stones, pyelonephritis, GI disease, pancreatitis, and cholecystitis. Mechanical tends to get better or worse depending on your position. For example, it may feel better when sitting or lying down. Typically, it feels worse when moving, can develop suddenly or gradually. Might sometimes be the result of poor posture or lifting something awkwardly, but often occurs for no apparent reason. The patient will come and he will say that he will present the history that I was bending and lifted a heavy object, and all of a sudden I started bending. So it could be a muscular strain or a ligamental strain. Inflammation includes age and onset of back pain less than 45 years, back pain lasting greater than 3 months, night pain, early morning pain and stiffness lasting more than 1 hour with serious onset, tenderness, inflammation over the joint, increased by rest and relief by activity. Root nerve compression, characterized by radicular pain arising from nerve root engagement due to herniated disc. Radicular pain then radiates into the lower extremity directly along the course of spinal root nerve. These are the dermatomes of neurological presentation: L1, L2, medial thigh, and mid-thigh and medial thigh, L3, L4, anterior compartment of the leg throughout the foot, L4, the medial compartment of the leg and the heel, S1, the lateral compartment of the foot and posterior leg and the posterior thigh. Malignancy includes metastatic tumors are found mostly in patients older than 50 years. Metastatic disease is more common than primary tumors of the spine, and the thoracic spine metastatic lesions are more common than lumbar. Patient usually has constitutional symptoms such as fever, weight loss, loss of appetite, and nausea and vomiting. Other includes in primary care settings, most of the cases are due to overloaded stool benefits, especially in pediatrics. Also think about psychological causes to avoid going to school. The prevalence of low back pain is more common in women than men, especially in pregnant women due to hormonal fluctuations and the decreased aortic curve. And psychiatric patients, 75% of depressed patients present with pain. One of the most common signs is lower back pain. The most common source of back pain, but do not sound serious and do not really cause long-lasting pain, arising from any combination of pathology involving disc, vertebrae, facet joints, ligaments, or muscles. The clinical presentation could be sharp, intense pain for 1 to 2 days. Muscle spasm, most patients recover within 3 months. The risk factors include lifting a heavy object or twisting the spine while lifting. Sudden movements that place too much stress on the low back, such as a fall, poor posture over time. Sports injuries, especially in sports that involve twisting or large forces of impact. Herniated disc, as I have give you a brief introduction to herniated disc, which is very common and a basic cause of low back pain. A complex multifactorial clinical condition characterized by low back pain with or without the concurrence of radical lower limb symptoms in the presence of radiologically confirmed degenerative diseases. The pain is exacerbated by activity but may be present in certain conditions such as sitting. As you can see here, the nucleus pulposus herniating into spinal canal. Radiating lower extremity pain in a abdominal distribution, history of bowel or bladder dysfunction, bilateral sciatica, and severe anesthesia may be symptoms of severe compression of the quadrilateral. Patients presenting all these symptoms, bowel and bladder dysfunctions. These are the red flag signs. As a physiotherapist, we recommend recommend these patients to visit spinal surgeons for the decompressive laminectomy and emectomy. These are the red flag signs. Positive straight leg raise or contralateral straight leg reproduced below 60 degree of hip flexion. Positive femoral stretch test messages upper lumbar disc condition. These are the myotomal and dermatomal distributions. I have made another presentation for lumbar inspection and examination. Spinal stenosis. Lumbar spinal stenosis refers to degenerative conditions of the lumbar spine. They narrow the spinal canal, lateral recess, and neural foramina. Facet joints and ligaments, hypertrophy, intervertebral disc protrusion, and spinalolisthesis may all contribute to the stenosis and symptoms resulting from neural compression of the chora inferior. And you can see the spinal canal is compressed. The disc is extruding into the ventral thecal sac, exiting on nerve roots. The presentation of spinal stenosis is intermittent pain radiating to the thighs or the legs, worst with prolonged standing activity or lumbar extension. Pain is typically relieved by sitting, lying down, or lumbar flexion. The patient may describe intermittent burning, numbness, heaviness, and weakness in their legs, unilateral or bilateral regular pain, motor deficits, bowel and bladder dysfunction, leg and product pain with standing and elevation. Patient walk in the forward flex gait, spinal stenosis. Patient will come into the OPD with flexible posture. Patients with vascular claudication have diminished pulses and typical skin changes such as mottled, discoloration, thinning, and shiny skin. These are the MRIs, shows the spinal stenosis at L4, L5 level. The disc is extruding into the spinal column. And you can see the space has been reduced. The disc has extruded into the spinal column. ये लिगामेंट फ्लेवर सर ये आपका पूरा लिगामेंट फ्लेवर की थिकनेस है स्पेटिस कितनी है ब्लैक जो पूरा लिगामेंट फ्लेवर है Thank you for the guidance, sir. As I'm not expert that much into the MRI clinics, but I think you people तो थोड़ी सी इंट्रोडक्शन हो जाए आगे बस आगे 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 सब मैनेजमेंट आ रही है So compression fracture, most orthopedic spinal compression fractures is present in isolated failure of the anterior spinal column due to combination of flexion and exit decompression loading. The stability of the spine is not compromised with this type of fractures. These fractures are traditionally considered benign injuries that heal without complications. I will overpass this as it's not. This is the low back physical therapy management of low back pain. But before going into the management, I will share the lumbar examination, which is very important to rule out the underlying condition of low back pain. So we have an energizer here. Again, first I will take a card, but we have an energizer here. I will take some time. Inspection is very important. Inspection is very important. Patients come with OPD. The first part of the low back exam starts with inspection. First, not a control of the spine, initiate a normal posterior curvature of the upper spine kyphosis and the normal anterior curvature of the lower spine lordosis. Lack of lumbar lordosis, a flat lower spine is often associated with low back pain. Inspection is best done by first observing your patient, first standing upright, then again bending forward while still standing. As you can see, a patient presently with increased kyphosis and the other patient with scoliosis, shifting the spine to the right side. Palpation is very important. The center of the back or the spinal region, pain here suggests pain from vertebrae. Just lateral to the center of paraspinal regions, pain here suggests pain from muscle strain of the paraspinal muscles. Provocative tests are important to rule out the reason of low back pain. Specific maneuvers are present. That's positive. If positive, these maneuvers suggest the nerve is being irritated by mechanical cause due to the vertebral bonds or herniated disc. Straight leg test, which is ideal test for to rule out the sciatica. The most common provocative test is the straight leg test. To conduct this test, have the patient lay spine and passively elevate the fully extended leg of the affected side to 30 to 60 degrees. You should need to extend the leg more than 60 degrees. A positive test will elicit pain in the region where the patient was complaining of pain in the pain, often rating down the leg. Yesterday, Dr. Gilgit has briefed me about a tripod sign, so I have read it thoroughly. Tripod sign is very good to rule out the sciatic nerve involvement. The tripod sign is a provocative test that is conducted while the patient is in the seated position. By elevating one of the legs, a positive sign will elicit pain in the back, again often rating down the leg, and should be accompanied by the patient's natural tendency to decrease the pain by leaning back and resting both arms on the table to support him or herself, thus creating a tripod. This is a good sign to use with patients suspected of malingering if they complain of pain. Failure to lean back and rest with both arms on the table may suggest the pain is not present or not related to irritation of the nerve roots. The femoral stretch is very important if low back pain is occurring from the upper lumbar region. Longitudinal exam includes motor examination, sensory examination, and reflex examination. In motor examination, to test L4 strength, have the patient's diet. I have already mentioned L4, L5, and S1 because this is the most prevalent in low back pain. To test L4 strength, have the patient slightly bend the knee and keep out as you keep pressure against the leg. Be sure to compare both sides to see if one side is weaker than the other. L5 motor exam to test L5 strength on pressure on the large toes and ask the patient to also flex the big toes and foot squats up. Compare both sides for relative weakness. This is the micro distribution of the L4, L5, S1. For S1, plantar flexion, putting pressure against the plantar flexion, heel walk. This is the most easy way. Patient could do himself Sensory examination. In the sensory exam, again focusing on L4, L5, and S1, we will look at specific dermatomal regions as noted in the image. If possible, use a minor fluid. If not present, you can use your fingers or the tip of the tongue to present the test for sensation. L4 sensory exam focus on the anterior lateral aspect of the thigh. For the L5 sensory exam, focus on the space on the dorsal side between first and second prong. For the S1 sensory examination, focus on the lateral aspect of the foot. Reflex examination, last. L4 reflex examination is tested by the patellary reflex, whereas the L5 reflex examination is tested by medial hamstring reflex. L4 is tested by, S1 reflex examination tested by the Achilles reflex, Achilles tendon reflexes. So, coming to the main topic, the original topic. But some background legal knowledge is very important. Obviously, on the basis of that knowledge and examination, we can make a diagnosis, we can make a differential diagnosis and actual root cause. Physiotherapy management for low back pain is becoming a first line of treatment. Manual therapy, starting from the manual therapy. Manual therapy is a very important component to manage low back pain. Joint mobilization is a treatment technique which can be used to manage musculoskeletal dysfunction by restoring the motion of the respective joint. The techniques are performed by physiotherapists who fall under the category of manual therapy. Spinal mobilization is described in terms of improving mobility in areas of spine that are tested. If the lumbar spine is stiff, if the mobility of the lumbar vertebrae are restricted, we put a manual mobilization, posterior anterior glide, to increase the flexibility of the lumbar spine. Transverse glide is there, posterior anterior glide is there, AP glide is there. For the acute back pain, early activation towards normality that includes exercises should begin in the primary care setting. In response to physical inactivity, skeletal muscles go through a process called adaptive releasing. Reductive rewarding results in a loss of muscle mass and changes in muscle composition, leading to a decrease in muscle strength. Sarcopenia, the spinal, paraspinal muscles, erector spinae, transverse spinalis, and abdominal muscles change in response to physical inactivity. There is atrophy and increase in fat content, increasing the risk of low back pain. Core strengthening exercises, really important to address the low back pain. You can do these exercises in at your work settings. If a person, as a clinician, if you people are suffering from low back pain, you can take a break and you can do these exercises. At first picture, we can see patient is lying in spine position, holding her abdominal muscles, and she's gliding her heels on the ground. Very good for core strengthening. It's a part of core strengthening exercise. And on the next picture, you can see that holding her abdominal muscles, contracting the abdominal muscles, and lifting her leg towards the roof. The third one is bridging exercises. Very important to ease the low back pain. Patient is in the spine line position, bending her both knees and lifting her pelvic off the floor. This is a cat position where the patient is in the leaning position and she is contracting, lifting her one arm. Even we can lift both arms up. Very good for the pain originating for cervical and thoracic lumbar as well. acute कंडीशन में जब तक पेन थोड़ा सा एडजस्ट ना हो तब तक हम ये एक्सरसाइज नहीं करते। पहले कुछ मेडिटेशन जैसे कि हैंडसेट्स हैंड ऑपरेट्स वगैरह से जब पैर सेटल हो, इन्फ्लेमेशन रिड्यूस हो, देन वी गो फॉर द एक्सरसाइज की जो इंडिकेशन ये है कि पहले इन्फ्लेमेशन कम हो, उसके बाद हमें एक्सरसाइज करवानी है। तो इवन के जो मैं अपने क्लिनिकल सेटिंग्स में जब पेशेंट मेरे पास आते हैं तो मैं हिस्ट्री यही देखता हूँ कि लीगल पेन इज परसिस्टेंट ग्रेटर देन 3 months जैसे क्रॉनिक बैक पेन, तो हम उनको एक्सरसाइज करवा रहे होते हैं, उनकी मेडिकेशन भी देखे होते हैं आया कि कौन सी मेडिकेशन दे रहे हैं। अगर वो किसी एक्यूट इंजरी के साथ आए तो वी जस्ट पुट आइस पैक टू रिड्यूस इन्फ्लेमेशन, और फिर सजेस्ट करते हैं कि आप किसी स्पाइन सर्जन या किसी मेडिकल स्पेशलिस्ट के पास आप कंसल्ट करें। This is the cane position to increase the strength of pain muscles. Patient could be in the kneeling position, putting both arms on the floor, lifting her back up and putting it downwards. Very good exercise to reduce low back pain. This is a prayer stretch. All this sajda हम सजदा नहीं करते, लेकिन सजदे की बड़े वो स्ट्रेच बनाते हैं जो आप करते हैं वो आप बता रहे हैं। मैं जो हाथ आगे कर रहे हैं ये वाला आप जिसको कहते हैं बर्ड डाउन, जैसे इस बाथरूम में ये लेफ्ट साइड है, राइट साइड की लेंथ उसमें स्ट्रेट की है और आप लोग को अपोजिट साइड आप भी करा मुझे जितना था और मैं अभी साथ में, लेकिन इसने गलत कर दिया, फिर डिस्क निकाल वो दोनों साइड एक से लेकर निकाला हो। Extension based exercises, Mackenzie extension, very important. In 1930s, Mackenzie, physiotherapist, a chiropractor has introduced this exercise. Mackenzie exercise regime used in the treatment of low back pain and sciatica, prescribed according to findings during mechanical examination of the lumbar spine and using a combination of lumbar motions, including flexion, rotation, side gliding, and extension. The goal is to reach full end range of extension if the symptoms are decreasing, centralizing, or being abolished, then the exercise is repeated as many times as needed. Particularly, jib patients की lumbar straightening होती है. The exercise shows the lumbar straightening. Mackenzie exercise is a miraculous on those patients. लेकिन spinal stenosis के patients में should be very cautious क्योंकि spinal stenosis में already मतलब intervertebral foramen की जो space है वो reduce हो जाता है, तो Mackenzie extension exercise तो फिर हमने बड़े ही supervision में करवाना होता है कि pain free range में वो exercise करें। सर ये बड़ी बेहतरीन exercise है, you can do it at home। अगर आप जब आपको लगे कि your low back is hurting, तो आप थोड़ा सा ब्रेक ले लें, you just do Mackenzie extension exercises, तो इससे काफ़ी आपको ठीक होगा। William flexion exercises are a therapeutic exercise regime used in the treatment of low back pain. It seeks to reduce lumbar neurosis for flexion of the lumbar spine and strengthening of the abdominal musculature. Particularly pregnant females के अंदर क्योंकि वो neurotic curve increase हुई होती है, तो उनके लिए William flexion exercises are mostly recommended कि सीधा लेट के bending their knees towards the chest and even more knees towards the chest. Very important exercise to ease the low back pain during pregnancy. Performing these exercises, we aim to strengthen the gluteals and abdominal muscles. The exercises were first developed for men younger than 50 years of age and women younger than 20 who had moderate to severe lumbar neurosis and whose plain radiological films revealed reduced space between the lumbar segments L1 through S1. Also, these patients had chronic low back pain that were mild to moderate in nature. The exercises proposed to open the intervertebral foramen to provide additional stability. हमारे पास यहाँ काउच नहीं है, वरना मैं प्रैक्टिकली डेमोन्स्ट्रेट कर लेता। Electrotherapy. an integral component of physiotherapy in managing low back pain. There are a wide range of modalities that can serve many purposes, including reducing inflammation, decreasing muscle spasm, and increasing local blood flow to improve the rate of tissue healing and decreasing pain. Hot and cold therapy, जो आप सर mention कर रहे थे acute जो आप मेंशन कर रहे थे कि एक्यूट फेज में क्या किया जा सकता है एक्यूट फेज में हॉट एंड कोल्ड थेरेपी इज वेरी इफेक्टिव cryotherapy is also an advantageous adjunctive modality. Acute can be used to control pain by constricting blood vessels and thereby decreasing swelling. It also can numb injured tissue by slowing down the nerve impulse. Moist hot packs can be used to decrease muscle spasm and improve relaxation prior to stretching. Once stretching occurs, there is less stiffness and increased mobility, allowing improved function.